Hi class, it's Professor Alabozic. We are now going to be going over your content for neuromuscular. The nervous system really is one of the most complex systems, and it really controls all of our body's activities. So very important part of our body. Next we have the readings, so readings in Lewis. So we go over a little bit of the nervous system and the structure and function, just a little bit about A and P. So that's Lewis chapter 55, Guillain-Barré syndrome, Lewis chapter 60, amyotrophic lateral sclerosis, also known as ALS, Lewis chapter 58, and Meniere's disease, Lewis chapter 21. Okay, so we're going to go over the structures and function real quick. So quick review of the nervous system, broken into two. So if you remember the CNS, central nervous system, that consists of the brain, spinal cord, and cranial nerves 1 and 2. And then there's the PNS, the peripheral nervous system. And that is cranial nerves 3 through 12. Also containing the spinal nerves and peripheral components of the autonomic nervous system, also known as the ANS. So again, our nervous system is one of the most complex systems in our body and is really responsible for our overall control of activities of our body. Again, like we talked about, it's divided into the CNS and the PNS. Does anyone remember the cells of the nervous system? Two types of cells. That would be the neurons and the supportive glial cells. And we won't get too much into those, but we will touch on them. So here's our cells of the nervous system. And here's our neuron, okay? So it's the primary functional unit of the nervous system is the neuron, and it has 3 characteristics. So it has excitability, the ability of excitability, conductivity, and influence. So excitability is the ability to generate a nerve impulse. Conductivity is the ability to transmit an impulse, so it's conducting along the way. And influence is the ability to influence other neurons and muscle cells. So here's a good picture of a typical neuron, and you probably remember this from A and P. So it's made up of a cell body. So the cell body is this big blue piece surrounding the nucleus, okay? There's multiple dendrites that come off of the cell body. They're finger-like extensions. And then there's a tail-like axon that comes off of the cell body. So again, coming back to the cell body, it contains the nucleus that's in the middle. That's actually the metabolic center of the neuron. And then, like I said, the dendrites come off of the cell body like little fingers, and these dendrites actually receive the impulses and signals from other neurons, and they conduct them towards the cell body. And then the tail, the axon, projects varying distances from the cell body and actually carries the nerve impulse to the other neurons or to the end organs. Okay, so this is just like a really complex transmittable system, really. As you can see, the axons are covered by a myelin sheath, and that's really what's used as an insulator for conduction. This myelin sheath will be mentioned in the following disease processes that we're going to go over. It's quite important to know because without that myelin sheath, we do not have that good insulator for conduction. And if we don't have good conduction, we're not going to have proper movement throughout our body, right? All right, so the other cell of the nervous system that we're going to talk about are those glial cells. So glial cells are divided into 2. There's microglia and macroglia. The microglia are like specialized macrophages. Remember what macrophages do? They eat back bad bacteria. Okay, so they're really responsible for eating the bad bacteria. So glial cells in general, they provide support, nourishment, and protection to the neurons, and they actually make up half of the brain and spinal cord mass. Microglia, they're capable of phagocytosis and they protect the neurons, and again, they act like specialized macrophages and they eat up the bad bacteria. They're quite mobile within the brain and they multiply when the brain is damaged. And then moving on to the macroglia. These are made up of astrocytes and oligodendrocytes. So first, talking about the astrocytes, they're found mainly in the gray matter of the brain, and they provide structural support to neurons, and they actually help form the blood-brain barrier. The astrocytes also help with synaptic transmission or conduction. And when the brain is injured, the astrocytes act as phagocytes for cleaning up neuronal debris. These astrocytes also help provide support for repair. So just like they're kind of like the mechanics of the brain. They try to restore neurochemical action and function. And then the other part of the macroglia is the oligodendrocytes. And these are specialized cells that actually help produce the myelin sheath of the nerve fibers. And these are found mainly in the white matter. So again, very important part of the neuron. Like I said, they produce the myelin sheath of the nerve fibers, and that myelin sheath is extremely important for nerve conductivity. So we're going to get right into our first disease process here, and that is Guillain-Barré syndrome, also known as GBS. Very, very rare, and it affects about one person in every 100,000 people. It really can occur at any age, but for those who are over the age of 50, they're more at higher risk. So as you get older, you tend to be at higher risk for GBS. And really, the cause is unknown. It is an autoimmune process that occurs a few days to a few weeks after a viral or bacterial infection, and that is what's been most seen with patients who have had Guillain-Barré syndrome. What's most typical for viral or bacterial infections is either if it's GI or upper respiratory tract are the most common. The most common type of GBS is acute inflammatory demyelinating polyneuropathy. So this is a subtype of Guillain-Barré syndrome, also known as AIDP. So this affects the cellular and humoral response and also creates injury to the myelin sheath. So you're like, humoral response, what is that? So the humoral immune system deals with antigens from pathogens that are freely circulating outside of the affected cells. And also cellular immunity occurs inside of infected cells and is mediated by T lymphocytes. Following an infection, the cellular or humoral response causes injury to what? The myelin sheath, or really the axon itself. What results is actually edema and inflammation of the affected nerves, and this results in segmental loss of the myelin sheath, and it actually exposes the nerve membranes within the axon. Another type of subtype of GBS is acute motor axonal neuropathy, AMAN, and this is actually most common in children, and this exhibits injury to the axon itself. The third subtype to Guillain-Barré syndrome is acute motor sensory axonal neuropathy, AMSAN. So just know these three types, okay? And know that with acute inflammatory demyelinating polyneuropathy, cellular and humoral responses are triggered. And again, the humoral immune system deals with antigens from pathogens that are freely circulating or are outside of the infected cells. And the cellular response occurs inside infected cells and is mediated by T lymphocytes. Okay, so following an infection, this cellular response or humoral response causes injury to the myelin sheath or the axon itself. So continuing with Guillain-Barré syndrome, so if there is no insulation to the nerve membranes, okay, so that axon, and if then insulation breaks down, the myelin sheath breaks down, what will happen to our nerve impulses? They'll either be slowed or stopped. Yeah, absolutely. So what is our body's response to that? What are our clinical manifestations due to the demyelination of the myelin sheath and loss of insulation? It would actually end up in like flaccid paralysis, really muscle denervation and atrophy of our muscles. And this is just an example, the picture. The one up top is showing, pretty good insulator here of the myelin sheath along the axon. And this shows how the myelin sheath has broken down, and it's actually showing a lot of the nerve membrane here along the axon. So possible causes, we've really found that the cytomegalovirus is the most common viral cause. And Campylobacter jejuni gastroenteritis is actually the most common bacterial cause, especially for the subtype AMAN. Epstein-Barr is noted to be related. Mycoplasma pneumonia, Haemophilus influenza, hepatitis A, B, and E, Zika virus, or if a patient's gone through surgery or trauma, sometimes that can, it's been found to trigger GBS. So again, research states that the cause is unknown, but it is noted that this autoimmune process occurs days to weeks post a viral or bacterial infection. The most common viral or bacterial infections are those of the GI or upper respiratory tracts. So clinical manifestations, how do these patients present? So it's very acute, and it's noted to be ascending. What does that mean? It's coming up the body, okay? So it's coming up from our toes all the way up to our head, okay? It's starting at our feet. It progresses very rapidly, and we note that there's symmetric weakness of the limbs, okay? And that's how it begins. So the first symptoms are weakness, numbness and tingling of the limbs, and again, it's symmetric. And we notice also hypotonia, which means reduced muscle tone. The patient's reflexes begin to be weak or even absent. And it is noted that maximal weakness can be reached in about 4 weeks. There's also autonomic nervous system dysfunction with VBS. So we tend to see orthostatic hypotension, hypertension, abnormal vagal responses that would be such as bradycardia. They may display heart blocks, even asystole, bowel and bladder dysfunction, facial flushing, diaphoresis. It is noted they may have extraocular eye movement and facial weakness, and that can be due to cranial nerve involvement. Also, dysphagia can be an issue, again, with relation to cranial nerve involvement. It is noted that the autonomic nervous system dysfunction occurs with the subtype AIDP and AMSAN. Also, these patients experience pain. They can go through, they tend to have muscle aches and cramps, as well as the paresthesia. And again, that is the numbness and tingling. Their pain tends to be more worse at night. So getting into more serious complications and what we really need to know as nurses and look out for if we ever do have a patient with GBS is, again, it's ascending, right? So as it ascends and up into our thoracic area, we're going to actually have complications with respiratory failure, okay? So that's our most serious complication with GBS. So that occurs if the paralysis actually progresses to our nerves that innervate our thoracic area. So what should we frequently assess for as nurses and watch for? Patient's respiratory rate, how's their depth, how's their work of breathing, how's their oxygen saturation? What would be immediate intervention for possible decline if a patient starts to have decline and it has progressed to their thoracic area? We would need to do intubation and they'd need to be on a mechanical vent until they have recovered from GBS or are starting to recover. So a lot of times the patient becomes completely immobile as the disease progresses up through the body. So what would the immobility from paralysis cause? What are some things that immobility can cause? And you guys know this. Could be a paralytic ileus. We'll have muscle atrophy. They can develop DVTs, even worse, a PE. Definitely nutritional deficiencies, skin breakdown for sure. Okay. I like this slide a lot. It just kind of gives a good snapshot of everything kind of that's going on with Guillain-Barré. So it is noted right up top here, it says weakness and tingling in your extremities are usually the first symptoms. And again, is that symmetrical or one leg? Should be symmetrical. Guillain-Barré syndrome, again, it's telling us that it's a rare disorder in which our body's immune system attacks our nerves. So the patient develops limb weakness, and that's usually first. And again, this is an ascending disease, and it works its way up the body. So the patient will have flaccid paralysis. It'll work its way up, possibly to having respiratory depression, shortness of breath, and even to the point of difficulty swallowing. And this is just showing you a picture of a healthy nerve with the myelin sheath intact, and the nerve fiber is not exposed. And then below it is the affective nerve with damaged demyelination, and the nerve is more exposed. So how do we diagnose this? Okay, so we really want to base this on the patient's history and also their signs and symptoms. So, what do we want to know? Have they had a past viral or bacterial infection, especially if it's respiratory or GI? We want to know clinical features needed for diagnosis, okay? So we need to know that if the patient has had progressive weakness in more than one limb, so is it symmetrical? And do they have decreased or absent reflexes? So these two clinical features are definitely needed for diagnosis of Guillain-Barré syndrome. And then we look at some lab studies. So we want to look at electrolytes, liver functions, erythrocyte sedimentation rate, or also known as ESR. So the reason we want to do electrolytes, we're especially looking at potassium, okay? So we want to rule out another disease process, also known as hypokalemic paralysis, which can mimic actually this disease, but the patient would have low serum potassium levels. So if they have the low serum potassium levels, that would be more of a diagnosis for the hypokalemic paralysis instead of GBS. So that's just a definitive measure to help rule out one or the other. There can be mild liver disturbances without unknown cause with GBS. So that's why we do liver functions. And studies show that the erythrocyte sedimentation rate, or the ESR, becomes higher in GBS patients due to tissue destruction and inflammation. So that's why we would test the ESR. We also test for the cerebral spinal fluid, or CSF, and that kind of just helps us exclude other causes. Well, lumbar puncture would be done for that. And we do this because in GBS, the CSF will have more protein than usual. We can also do an electromyography, or EMG, and also nerve conduction studies. These are typically used after 2 weeks to confirm a diagnosis. So nerve studies in AIDP actually show demyelination. This can help with the prognosis, really, because if demyelination is seen, the patient often goes into respiratory failure, needing mechanical ventilation. So it's a little bit proactive, and we kind of know what we're looking at. So it really helps the provider determine the subtype of GBS, and that's why these studies are done 2 weeks after the fact. So nursing care. Okay, what do we need to do for these patients? How do we care for these patients? So ventilatory support is very critical, especially if the patient is experiencing the respiratory distress or depression. And really what's more important than that is actually the assessment for respiratory depression before it's even happened. So if we have a patient admitted to us with Guillain-Barré syndrome, we know that it's ascending, right? So if they haven't had that respiratory depression yet, it's something that we really need to monitor closely, okay? So always monitoring their respiratory rate, their depth, their oxygen saturation, their work of breathing. Hopefully it doesn't get to the point of the thoracic area in respiratory depression, but if it does, we know what to assess for and we know what to do. So the patient will need to be intubated, placed on a ventilator, just to get them through this acute phase and to get them better. So the patient will need to go to ICU, critical care, for hemodynamic support and monitoring. So again, we're monitoring respiratory function, EKGs, blood pressures. The patient, as we noted, can be either hypertensive or have orthostatic hypotension. EKGs, as we've noted, that there can be rhythms. They can have certain type of blocks or even asystole. They can develop fevers. And the most important reason why they would be in the ICU if they were to go into that respiratory depression, they could be intubated very quickly and placed on a ventilator right in the unit. So patients who do have GBS, they will undergo what is called a plasmapheresis, also known as a plasma exchange. And what the plasma does is it actually removes antibodies and other immune factors. This plasmapheresis is actually used 5 times, either daily or every other day in the first 2 weeks. Okay, so daily would be for 5 days straight, or it would be used every other day for the first 2 weeks. Also, high doses of IVIG, or IV immunoglobulin, could also be used as treatment. So what IVIG does is it interferes with antigen presentation. And again, this is very similar. It's given over 5 days. And this actually tends to be the preferred method of treatment for GBS. So about after 4 weeks, both of these medications have little or to no value in helping the prognosis. Okay, so we hope that we can get the patient through this quicker than 4 weeks. If we're coming up to past 4 weeks, these medications will really not help and their prognosis becomes more slim. So again, continued assessment during the is critical during the acute phase. So we want to always assess any motor sensory function, and we need to report any changes immediately. So if we see all of a sudden, a sudden atrophy or a sudden decrease in movement, we would need to tell the provider immediately, especially because this is so quick and it's ascending, and it becomes definitely more of an emergency once it reaches the thoracic region. We want to check reflexes of the patient, cranial function, nerve functions as well, level of consciousness. So we want to always check mentation with the patient, their pupils, how's their gag, how's their swallow, because especially if it moves up and affects their swallow or their gag, we would be at huge risk for what? Aspiration. So this ascending paralysis is a huge concern and something that we need to monitor very, very closely. Also monitoring the assessment of the respiratory and cardiac functions. So these patients are at an increased risk for dysrhythmias, like I said, heart blocks and even asystole, even orthostatic hypotension they're at risk for. We can monitor ABGs, and that can kind of let us know, especially if they're going into respiratory depression. We'd see decreased work of breathing first more than anything, but ABGs can give us some good numbers on whether the patient's retaining CO2, not blowing off CO2 properly, and having respiratory depression. An end-tidal CO2 is a great thing to have on these type of patients, and it will kind of help us determine respiratory depression earlier, more than any other number itself. Monitoring their respiratory rate, their depth of breathing, O2 sats, what's their work of breathing. Again, monitoring their blood pressure, their heart rate, their rhythm. Patients may need a vasopressor if they go on the spectrum of the low blood pressure side. And always monitoring for fever. So if a fever develops, we may need to take either a sputum or blood culture for the patient. So meeting nutritional needs, this is really important. They may get to a point where they may not be able to swallow and take in nutrition, okay? So there may be a possible need for a G-tube, an NG tube, depending on how long these patients are sick for, especially intubated and on a ventilator, how long they'll be going without nutrition. And at times a nasogastric tube will be placed. A G-tube is actually for more chronic cases. But they do need to get some sort of nutrition, whether it be tube feedings or TPN. If they do, like we talked about, if they do lose that gag reflex, there's a huge potential for aspiration. So we really need to be careful with that. And a big thing too is actually to know if the patient's drooling or having any other issues with not being able to control their own secretions. That can mean that there's a loss of gag reflex as well. So early referrals should also be made to like PT/OT to just work with the patient, probably do whether passive range of motion would probably be the best option for these patients, just to keep their joints active, their muscles active. It helps with skin. Also providing emotional support for the patient and the family. I can't imagine how scary this is for a patient to be going through this, knowing that this disease is quickly ascending and they may need a possible, ventilator assistance for their respiratory system. That must be very, very scary for the patient. Also for the family, because they can see it happening so quickly right in front of their eyes. It is noted that most patients can recover spontaneously around the 28-day mark. It's kind of like the magic number for GBS. 80% of patients tend to walk independently at about 6 months after really good physical therapy. And 60% of patients make a full recovery in 1 year. So it's a long, long road. It's a long disease process and it's a long recovery process. Typically, we see patients who have had a GI infection are more older in age. They have more of a rapid onset with GBS, and they actually have a longer hospital stay. These patients also tend to have poor upper extremity motor strength, and they typically need a mechanical ventilation with a poor prognosis. So again, this is typically for patients who have had a GI infection and who are older in age. So remyelination occurs very, very slowly, and this is why it takes about 28 days for patients to start to recover. So it's very slow regrowth of the myelin sheath to regain neurological function. And how do you think neurological function is regained? So what happens? So this is an ascending disease process. So it starts in our feet and works its way up symmetrically. How do you think these patients get better? It's actually descending, so it's opposite. So the patients will start to get better from their head down to their toes, okay? So proximal to distal, absolutely opposite of how the disease process originates. And this is a good little video that we'll watch on GBS. And we're going to move right along onto amyotrophic lateral sclerosis, also known as ALS. So this is a very rare disease. It's a progressive neuromuscular disorder, and it's a total loss of motor neuron function. This disease unfortunately leads to death in about 2 to 5 years after diagnosis, typically. We've heard about this, the famous baseball player, Lou Gehrig, was stricken with this disease in 1939. And also, you've probably heard about Stephen Hawking. He was diagnosed actually at the age of 21, and he lived for over 50 years. He passed away at the age of 76. So he beat that 2 to 5 year sentence there. So he lived for quite some time with this disease. This tends to be more common in Caucasian men, and what's really, really interesting is actually common of veterans in the Gulf War. They seem to have ALS twice the rate of the general population. So a little bit of research on this has stated that they think there's been exposure to lead and pesticides within that Gulf War, and that's where that comes from. About 20,000 Americans have ALS, and the typical onset of this disease is between the ages of 55 and 75. So what happens is motor neurons in the brainstem and spinal cord gradually degenerate for unknown reasons. It's really unknown. They're thinking there's some hereditary issues within there. So think about it. A motor neuron is completely dead. So a dead motor neuron cannot transmit or produce signals to the other neurons or even our muscles itself, right? So it's not going to produce movement, okay? So what the real scary part of this disease is that the patient's brain is functioning totally fine. They're totally with it, and it's trying to send impulses and, move my arm. I want to move my leg, and it's just not connecting. The nerve impulses are not connecting for what the brain wants your body to do. So you're pretty much trapped within your body. And I can't imagine how scary that is for some patients. So the electrical and chemical messages that are originating in the brain are saying, okay, let's get moving. I want to walk, but the impulse cannot reach the muscle. Cannot reach it, or it just doesn't activate it. So the brain is really, really good. The impulse is not, and we're not going to get that good movement at all. And like I said, about 5 to 10% of cases through research are really shown to be genetic. So there is some genetic and hereditary factor there, but for the most part, this is unknown. So how do these patients present? Clinical manifestations. So the classic sign here is progressive muscle weakness and atrophy. And these symptoms can initially affect the arms or the legs, so it's limb onset, and that's what it's called, limb onset in ALS. That's the term for if it affects the arms or the legs, okay, first. We may note that the patient can have trouble with fine motor tasks such as writing and typing. These patients tend to start stumbling often, trip often, drop a lot of items. And then some have onsets more of like where there's issues with slurred speech and swallowing. And that first onset is called bulbar onset ALS. So there's limb onset ALS and then there's bulbar. So it depends on which starts first, okay? What symptoms first start. And what happens is there's a lot of muscle wasting with this disease process, involuntary contractions. And that's happening from denervation of the muscles and lack of stimulation and use. So continued signs and symptoms or clinical manifestations. The patient can develop sleep disorders. They might not be able to sleep well at all. They can develop pain, spasticity in the limbs, drooling, emotional lability, constipation, esophageal reflux, depression, problems with decision making, memory. Unfortunately, death occurs due to respiratory compromise and due to the weakened paralyzed respiratory muscles that just cannot be fixed. So once it reaches that area, we have respiratory compromise, and the patient hopefully will have made the decision to whether or not to stay on a mechanical vent or have hospice or DNR, DNI. So that is a big decision for the patient that they have to make, an unfortunate one. So this illness is very, very devastating because, again, the patient is cognitively intact while they're wasting away. They have developed something that's called voice banking for ALS patients. And this is actually used as more of like a proactive tool for communication, knowing that at one point they'll not be able to communicate. So again, I can't imagine how scary that is for the patient to think about this and have to make this type of decision to do voice banking. But of course, the loss of any voice or communication can be very, very isolating and scary to the patient. So patients with ALS can actually take part in what's called a voice banking program, and they can record a lot of like key words that they like to use a lot, key phrases, maybe even like short sentences of their own voices. And once they've reached a point where they can't communicate anymore, this can probably be a type of audio for them to select, like a button, and they'd press what type of statement that they want to be said. So the voice banking is meant to be an alternative communication tool when patients may not be able to speak anymore. So nursing, what do we do? Okay, so a few medications here. So Riluzole, I see this on TV all the time. The other word for this is Rilitech, and this actually helps slow the progression a little bit of ALS. And what this does is it reduces damage to the motor neurons by decreasing the release of glutamine in the brain. You might have heard of this one too, Endarvoni or Radicava. This is actually new in May of 2017, so fairly new. The first new drug treatment for ALS. And this is given IV daily for 14 days in a row, followed by a 14-day drug-free period, and then you'd go back to your 14-day IV. So 14 days on, 14 days off, 14 days on, 14 days off. And what this medication does is it relieves oxidative stress, which is a likely factor in the progression of ALS. Unfortunately, there's no cure yet. Treatment options are limited, unfortunately, but these are two medications that can hopefully slow the progression. And nursing care continued. So we want to help the patient, guide the patient in the use of moderate intensity endurance type workouts and exercises, especially when they can still move their limbs, or at least their trunk and their limbs. And really exercise like this, continued movement, really helps with the reduction of spasticity, even reduction of pain. We want to help reduce any aspiration risks. So if they're starting to have trouble swallowing, if they're having, early stages of paralysis with this swallowing, we would want to make sure to watch out for any aspiration. We want to watch for any respiratory compromise or respiratory insufficiencies. Very similar to GBS, we'd want to continue to monitor their respiratory rate, their depth, their O2 saturation. We want to help facilitate communication, and maybe they have done that voice banking, which would be wonderful. Again, decreasing pain from muscle weakness and really using that moderate intensity workouts can really help that. Safety. Okay, if the patient's still able to walk, or we don't want them falling out of bed, we want to really decrease falls and any injury that the patient may have. Offering that emotional support, providing diversional activities. What do they like to do? What are their hobbies? And really fill their life with what they love to do. And also helping the patient discuss advanced directives. What are the patient's wishes when they get to that point of needing a mechanical ventilation, needing nutrition through a PEG tube. So we really want to talk about quality of life and life support. And this is a video on ALS. So moving on to our last disease process, and this is Meniere's disease. And this is a disease of the inner ear. And it's a progressive disorder leading to an accumulation of endolymph in the labyrinth of the inner ear. So we got a lot of big words here. So this is really a big overlap between manifestations of inner ear problems and CNS disorders. So we talked about endolymph. It's actually it's the fluid contained in the inner ear, and the labyrinth is known as the inner ear. So accumulation of fluid, in the labyrinth of the inner ear. The major cation in endolymph is potassium. And again, that labyrinth is in the inner ear, and this contains the organs of hearing and balance. So if we're having a disease process that's affecting the labyrinth and causing excess fluid to sit in the labyrinth, what do you think we're going to have problems with? Definitely hearing and balance, probably almost like very severe vertigo issues, okay? Meniere's disease usually only affects one ear. And the cause is unknown again. So this is the third disorder we've talked about, that the cause is unknown. They're thinking genetic and environmental factors can play a role. Symptoms typically begin between the ages of 30 and 60 years. And this tends to be more common in women. So again, in Meniere's disease, we have excess fluid and pressure leading to hearing and balance problems. So we have the excess fluid that sits in the labyrinth. The patient can definitely go through episodic vertigo. They can have tinnitus, ringing in the ears, or they can feel that ear pressure and sense of fullness in their ear. So these patients will have progressive hearing loss that can occur over time. And patients will have a significant disability due to the severe attacks with vertigo. So when they're in like an acute severe attack, they're completely out for the count, very debilitating. These patients go through severe nausea, vomiting, sweating. Patients may actually have a feeling like they're being dropped or pulled to the ground. These are called drop attacks. And some patients actually report that they feel like they're whirling in space. And attacks of Meniere's disease may last from hours to even a few days. And this can happen several times a year. Patients, you know how when a patient has like a seizure, they have like a little aura, they kind of feel like they're going to have a seizure prior. There's something slightly similar to Meniere's disease. So the patient will actually develop a sense of fullness in their ear. They'll have increased ringing in their ears prior to an episode, and the hearing will be muffled. So these three things is going to show that there's going to be an attack coming soon, a Meniere's disease attack. So how do we diagnose this? So we want to get a good history and physical, and we know the cause is mainly unknown, but it can be genetic. The patient will have a low frequency sensorial neural hearing loss on audiogram. The patient will need a documentation that they've had 2 or more spontaneous episodes of vertigo, and that is actually a clinical indicator, a clinical diagnostic key. Studies have shown that there may be speech discrimination or tone decay. There's actually vestibular tests, which includes caloric testing and positional testing. These will be abnormal. And then there's the electronystagmography, or ENG, and that is used to evaluate people with vertigo. So a false sense of spinning or motion that can cause dizziness. A certain other disorder that can affect hearing and vision as well. So what they do is electrodes are placed at locations above and below the eye to record the electrical activity going on. And then there's the glycerol test. So a patient receives an oral dose actually of glycerol followed by serial audiograms over 3 hours. So if there's noted to be actually an improvement of hearing or speech discrimination, this really helps support a diagnosis of Meniere's disease. So what happens is why they give the glycerol is the glycerol promotes like an osmotic effect, and it pulls fluid from the inner ear out. So if we notice that there's a progressive improvement, we'll note that the fluid is getting pulled out of the inner ear, and this is probably a really good diagnostic factor. And management for Meniere's disease. So unfortunately, no cure exists currently. And really the treatments aim to reduce the number of vertigo attacks. So it's treating more of an acute attack situation than a chronic. Then there's drug therapy. So the patient can receive anticholinergics, antihistamines, antiemetics, especially if they're suffering from nausea and vomiting from a type of vertigo attack. Benzodiazepines, so that can help with pain control, and corticosteroids can help with strengthening. There's also some surgical intervention for Meniere's disease. So there's endolymphatic sac decompression. There's endolymphatic shunting. So this reduces the pressure on the cochlear hair cells and prevents further damage and hearing loss. Then there's the vestibular nerve section. So it's actually cutting the nerve. And if relief is not achieved by this procedure, this vestibular nerve section is actually done if the endolymphatic sac decompression or the endolymphatic shunting has not worked properly. They'd move on to the vestibular nerve section. Sorry about that. the labyrinthectomy, so they're actually taking out the inner ear. And then there's surgical ablation of the labyrinth. So this is done when actually involvement is unilateral, so it's only on one side. And this actually, when they do the surgical ablation, unfortunately, it can result in the loss of vestibular and cochlear hearing function. So the patient may lose a little bit of their hearing function if they did a surgical ablation of the inner ear. But just to have, decreased severe vertigo attacks, the patient will go through this. And then there's the injection of gentamicin. And this actually results, unfortunately, in inner ear damage, but it helps the reduction of endolymph production, so the reduction of the fluid inside the inner ear. So nursing care, what can we do for these patients, especially if they're going through an acute attack here? So we want to provide patient safety and plan interventions to minimize any vertigo attacks, okay? So what do we want to do during an acute attack? Probably want to just keep the patient quiet in a quiet room, lightly lit or a darkened room. They really don't need bright lights. And to help minimize any vertigo attacks, we want to avoid any sudden head movements, quick head movements, jerky movements, or quick position changes. We can have the patient close their eyes until the vertigo stops if that helps the patient. We want to avoid, like I said, any bright lights, flickering TVs, fluorescent lights. These patients tend to be very nauseous and they tend to vomit, so keeping some sort of basin by the bedside to make sure that the patient can reach it. Definitely fall risk precautions, so we want to ring for help to ambulate, right? So if they're going through vertigo, acute attacks, they'll be off balance, they may have a headache, they'll have, vision changes, hearing changes. So always ringing for help to ambulate for these type of patients is beneficial. And this is a pretty good video on Meniere's disease.